Hello, this is Dr. Mintz. This is a patient who had pelvic pain, a male, and I'll give you a chance to look over the case a little bit here. This is an example of a patient that's scanned using a protocol we call CT renal colic or CT urogram. The patient is lying on their belly, also known as prone, and that's kind of helpful sometimes because they can have distal ureteral stones. We see distal ureteral stones quite often, and let's see if we can follow these ureters. That's one of the tricks of the game, is to follow that ureter there. And let me zoom in a little bit. There it is there. And you can still follow it if you're careful. You can stay right with it right there. Okay, and here it is here. And you should be able to see it join the bladder. And it's not this, it's this little thing right here. So let's see, and sure enough, there it goes right to the bladder. And the same kind of thing happens on the other side, and it's an important skill to develop if we want to be able to look at these studies and determine if there is an abnormality related to a distal ureteral stone or some other process. We put the patients on their belly, we put them prone like this, because then if there is a calcification in the back of the bladder, maybe in the ureterovesical junction, if the patient's lying supine, it can be hard to tell whether the stone is actually lodged in the ureterovesical junction or if it's actually just lying right near it, because it can be, as you see, very hard to see the distal ureters. So we place the patient prone, and that allows the stone to fall forward. It makes the stone a little bit more conspicuous too, because in general you'll often see venous calcifications called phleboliths in the pelvis, and you'll have them here and there, especially down in the lower pelvis like this. So it can be a little hard to tell whether you're dealing with a ureteral stone or a calcification. This is a good example. That's a classic phlebolith. It's just a calcification we see in the vein. They're so common we rarely mention them unless they are producing some difficulty for our interpretation. And what we do see in this bladder, though, is a nice example of a bladder stone. We don't see those very often. I may see a handful in the course of a year or less. But this is a nice one because it's stellate. It has nice margin that looks kind of irregular, but kind of a star-like configuration. So this is a good example of some of those principles, as well as a nice finding of a bladder calculus. Now this is an altogether different type of process, and let's see if you can see what the abnormality here is. So we'll go through it as I always do, just looking carefully for anything that might catch my eye. Alright, it's nice to give a case like this a quick going over before you jump into one area. It's important to develop a systematic approach to viewing any of these CTs, especially CT abdomen and pelvis and CT thorax, body imaging, because you'll get distracted by a finding that looks very interesting or you're not sure what it is, and you can overlook something that didn't initially catch your eye that can be very important. So very important to have a systematic approach. So you probably noticed right off the bat that there are renal cysts. Okay, well that's fine. They're usually benign. You should learn the Bosniak categories, B-O-S-N-I-A-K, which is something that's come out in the past few years and has helped us with more certainty determine whether a cystic mass of the kidney can be left alone or whether it needs further evaluation. So this is a simple benign cyst, a Bosniak category 1 cyst on a scale from 1 to 5, because it's smoothly marginated, uniformly low in attenuation, and doesn't have any soft tissue components to it, and no calcifications. And similarly over here, it can be a little more difficult when it's a very small cyst to characterize it as confidently, but very often we can. And here's another cyst on the left, That looks like a Bosniak category 1. And a little one here that also looks like a Bosniak category 1, which means definitely, pretty much definitely, benign. And then we go into the pelvis, so we really haven't found the problem yet. Cysts can cause pain, but not very often. Very often they're just incidental findings. If they bleed, which is uncommon, that can cause pain. So there is another finding here. Can you see it? Can you see it? And what we have here, what is all this bright white stuff in the urinary bladder? It's contrast, and here you can see the ureters on both sides. You see now this is, one of those is ureter here, and one is not. One is going to be a vascular calcification. And these here that are more anterolateral look like they are the ureters. Here they are here as we go up, up, up to the kidneys, and you see each approaching the renal collecting system on both sides. And contrast in the renal collecting system. So then, what is it that we have down here that I am leading you toward? How would you describe the appearance of this bladder? Well, if we change the windowing, suddenly you can see a little bit more clearly what's happening. It's almost like you need sunglasses for this setting. But if you look here, you'll say, okay, I see a urinary bladder like this. I see two distal ureters, or the ureterovesical junctions, present on both sides. I see contrast getting into the urinary bladder, which is basically urine that is opacified with iodinated contrast. It's the iodine compounds in the contrast that gives it this high attenuation, so that we call it dense. But this doesn't look quite right, does it? Because you'd expect it to be layering as a heavier liquid posteriorly with the more simple fluid of urine more anteriorly. But this has an irregular margin, and what you're seeing here is a filling defect. We see filling defects in many areas of radiology, and in the bladder it's very concerning if it is not a stone, and this certainly does not look like a stone, because this is very suspicious for cancer. This is very suspicious for bladder cancer that is arising in the anterior part of the urinary bladder. And so as the patient is lying supine, the urine opacified comes into the bladder, and it is outlining very nicely this mass, which is a bladder carcinoma. Now this is one of my favorite GU diagnoses. It's something we weren't able to diagnose until fairly recent years with higher resolution scanning. This patient has abnormal kidneys. I'll just tell you that right off the bat here. Can you see what is the nature of the abnormalities? So let's shrink it down a little bit. There's something here. Is that a Bosniak category 1 cyst? No. You can see it's not really well marginated. It's not uniformly low in attenuation, and it really looks like it's enhancing a little bit. How about this? Is that a Bosniak category 1 cyst? No. First of all, it's not in the kidney, and second of all, it's the gallbladder. Okay, so look at this left kidney now. This is very interesting. Ordinarily, normal kidneys will enhance very uniformly, and notice also very, very symmetrically. There are phases of renal enhancement that occur over a relatively short period of time, but they are pretty much right on the button when it comes to being quite even from one side to another. So here you see nice renal cortex enhancing with little enhancement as yet in the renal medulla, and here you see the same thing, not quite as high up, but if we go up high there you see the same kind of thing. This sometimes looks like a sliced tomato, is kind of the architecture of a kidney in the axial plane. So everything looks hunky-dory around here, but this looks fuzzy. You don't have that nice sharp margin of enhancement in the cortex and the nice margination between the renal cortex and the medulla. And you have that on both sides, that is that sharp contrast. But here also you have this vague area, hard to describe, but gee, you should really be seeing cortex coming all the way around there, and we're not. Let's see if we go down. Oh, here's a little bit of abnormality here too. Got to look carefully, but here you can see this renal cortex here is being interrupted by these areas of diminished enhancement. And then let's look on the left side and see what else we can find. Ah, there's one. That's a little thing right there. Now that doesn't look very impressive, but let me tell you, if you see that, you can be pretty darn sure, given the right clinical situation, that the patient has what this patient has. And what this is pyelonephritis. Pyelonephritis is a kidney infection, very often bilateral. That's what you're looking at here. This is a classic, typical appearance of pyelonephritis. We didn't used to be able to diagnose this very easily by imaging, and it was almost always a clinical diagnosis. The urine specimen would have white blood cells in it, often red blood cells as well, some bleeding related to the inflammation, and they would be able to grow, if not immediately see, bacteria in the urine. But this is a way of diagnosing it, sometimes earlier, and every time you see this, you give the doc a phone call and you say, could this patient have pyelonephritis? And they'll say, oh yeah, that's what I thought it was, or we were pretty sure that's what it was. So generally, these patients present with a fairly typical clinical history, so you're not pulling a rabbit out of a box when you call a doctor or let one of the healthcare providers know that this really looks like pyelonephritis. Either they knew it and they were looking for something else, or they were pretty sure and they just wanted to be 100% sure. So this is a good example. If we look at it now on the coronal images, you'll see how much more nicely those findings stand out. So you've got this wedge here. It can almost look like an infarct, but it's not. Infarcts can be wedge-shaped like that. And this area here in the upper pole of the left kidney, very indistinct, mushy appearance of the enhancement instead of having a nice sharp margination. So this is typical of pyelonephritis, and if you see a case and you just see a little something like here, that one little area of abnormality there, or something very subtle on one or both sides, and you're afraid to say, hey, could this be that? Like this right here, for example. That right here, see if I can sell this to you. This is a diagnosis, right here. Nothing else. You see this, unless it's an older person with old ragtag kind of kidneys, and this is not that kind of patient. If you see this, you can be pretty darn sure that if you call the ER doc and say, I think this patient's got pyelonephritis, they'll say, sure enough, we just saw white blood cells in his urine, thank you. So a very important finding, classic, indisputable in this particular case, but even when it's much more subtle, as the area I was just pointing out, you can make the diagnosis, and that can be very helpful. Now, this is a very common, relatively common disorder that we are usually very impressed by when we see it. Now, this is very asymmetric, right? What is asymmetric? Okay, we're looking at kidneys, and we say this left kidney shows very uniform distribution of contrast, which means it's gone beyond the stage of the case that we just looked at where we had cortical enhancement but no medullary enhancement. Here we have cortical and medullary that has pretty much equalized. You look over here, first of all, there's just cortical enhancement, and the cortex is very thin. Now, you think maybe this could be an obstruction. Maybe this is all a dilated collecting system. We will see. It could be that. Obstruction that produces that much dilatation usually impairs the renal function quite a bit, though. So if this were really an acutely obstructed ureter, let's say, a stone, yes, the kidney could get bigger, but not this big. Yes, the collecting system could get more dilated, but not this dilated. And you would not expect to see the cortex enhancing so nicely as in this case. And if you look closely, you'll see this is renal cortex, and you see renal cortex over here. Well, they're both enhancing about the same, right? You see that? This is pretty bright, pretty white, light. This cortex on this side and this pretty equal. So what does this represent? What would give this appearance? This is a chronic UPJ obstruction, a chronic ureteropelvic junction obstruction. So why is it that an acute stone would not give you this appearance, and a chronic UPJ obstruction, which typically has been present for years, if not the patient's entire life, the kidney acclimates to the back pressure from the obstructed ureter at the ureteropelvic junction, and here again the coronal images are very nice to look at here. So here you have the two kidneys, nicely enhancing cortex, about the same phase as on the other side. Now we don't have much renal medulla here to talk about because it's all dilated collecting system that has expanded out to the cortex there. So this kidney has acclimated to this long-standing obstruction, and even though the collecting system has dilated, the pressure of the renal dynamics filtering the blood and producing urine, that kind of pressure in toward the collecting system, which initially met a great deal of opposition, now has balanced out over the years. So this kidney, although not the best kidney in the world, has been chugging along and doing a reasonable part of the work. This has probably been doing, you can probably make an estimate looking at it. This has probably been doing 80% of the urine production, and this maybe even less than 20%, maybe 10 or 20%. Hard to tell. Now that could be analyzed with radionuclide nuclear medicine imaging. That could be contributory there. But this is important to realize that this is not acute. So these are the findings in a chronic UPJ, a chronic ureteropelvic junction obstruction. And what you don't see here that you would have in an acute obstruction is an indistinct margin of the kidney, and you don't have stranding in the perirenal fat. If this kidney were that backed up acutely from a stone, besides the fact that the patient would be writhing in pain, the renal cortex would not look nearly as clean and neat as this, and the surrounding soft tissues would be infiltrated. And remember, the kidney is situated in the perirenal space. And so it's surrounded by fat to one extent or another, and those spaces, the perirenal and pararenal spaces, are extremely variable. This person has just about none of either. They're thin, and they've taken a lot of the fat away from that area. But other people, many people that you see on the street and in the ER these days are going to have a much more copious quantity of adipose, and there'll be plenty of fat around the kidney to get infiltrated. But even the little bit that we do see should be reasonably conclusive to say this is a smoothly marginated kidney with no infiltration of the adjacent fat, and that's exactly the case right here as well. So a nice case of chronic ureteropelvic junction obstruction. Well, I think you're getting the idea that I'm giving you the axial images first because they can be more difficult, although they do facilitate a more systematic approach to this imaging. But I'm going to jump to a coronal right now because I've got an interesting case here that I think looks very clear in terms of what's abnormal on this coronal set. So, something's wrong. And you're saying, well, either he's got one funny looking kidney, or he's got one funny looking kidney and an even funnier looking kidney over here on this side. But no, that's bowel, and this is kidney. But what in heaven's name is wrong with it? Well, let's look at it more closely. Let's start and slowly progress. Let's say smoothly marginated, okay. Nice thick cortex. So here you have this margin of the kidney right here. So if we look at this case, you'll say, you've got a really long kidney on one side, and we don't have any kidney on the other side. Well, it seems to me that maybe the left kidney has moved over to the right side, where it doesn't belong, and just joined at the hips with the right kidney. Well, that's pretty much the situation here, and we don't phrase it in that manner in medicine. We call it crossed fused renal ectopia. So ectopia means in the wrong place. Ectopic pregnancy is a pregnancy that's in the wrong place. This left kidney is in the wrong place. In fact, I'm not sure we can reasonably call it the left kidney, but it would have been the left kidney had things gone a little better. But what has happened is that it has developed on the right side and has remained fused with the right kidney, and so it is crossed from the left to the right. It's fused, and it's renal because it's kidney, ectopia because it's in the wrong place. So this is crossed, fused, renal ectopia. And these people could be perfectly normal, and they might come in when they're 50 years old, and you do a scan and say, guess what? You have one weird-looking kidney instead of two, and they'll be flabbergasted, but they've never had a problem from it. Now, sometimes these patients can be more prone to getting obstruction or stones, but very often we'll just find it as an incidental finding. Let's see what the sagittal images look like. Poor little sagittal images, people give it very little respect. Okay, now this is really displaying this very nicely. Look at this. This is ideal. Now, there's not a lot that I would run to the sagittal for, except for maybe sagittal views of a spine. But look at how nicely this displays the anatomy. You can kind of see that, okay, here we've got one nice little kidney, not kitty, kidney, and we go over this way, and you can kind of tell that there's another kidney right here. So you have two kidneys stuck end to end, joining and sharing, really not separately joining, but having developed in such a manner that they share a large area of cortex between them. And so we have the would-be native right kidney and the should-be left kidney here on the right. And this is a very nice example of crossed fused renal ectopia.